everybody who's watching the live stream. I'm sorry for the late start. We are 9 minutes late, but that's all right. We will get to it right away. Doc Pat, I'm going to give the floor to you so we can start our Quizmaster right away. Hit it. Ay, wait lang may poll ba to? Okay, sige. So, I'm going to give the poll. So, ganito na lang wala na magbabasa ng question. I'll give you 30 seconds to answer, 45 seconds pagka matagal. And then after that, si Doc Pat will proceed to the rationale. That's correct, no? That's how it's going to be. Troy?
Yes, Doc.
Troy, ganun, no?
Yes po, Doc.
Okay.
Yes.
All right, share screen na tayo, Doc, and let's do this. Hold on, please.
Will I be sharing the questions, Doc, or with Doc today?
No, I will be sharing the questions, I think.
Okay, Doc.
Okay. Oh, hold on, walang sound. Sorry po. Give me a moment, sandali. Ooh, what out? Okay.
Doc, ako na mag-share.
Ako na. It's here. I'm, ano lang. Okay, here we go. Okay, good morning, everybody. Let's start. Let's get the ball rolling. Okay. First question. Teka muna, I will set timer up.
Doc, Rocky may timer na per slide, so you don't have to do the timer already. Just press enter.
Oh, shush. Okay, ready, go. All right. And press enter now. The poll is open now. You can answer. Troy, okay na, no? We'll move.
Yes po, Doc.
Next. Question number 5 na tayo, guys. Relaunch. Sandali lang. Okay, question number 6. Should I give you guys more time to answer? Wait. Question number 6. Bato sandali. Results. Show ka lang ha. Sorry, hindi ko pala na-share yung iba. Number 6, ayan. Next question. Your answers. Guys, sagot kayo ha. Next one. Okay. Next one. Teka, share ko muna yung results number 8. Yan. Okay. Next. Last question. Okay. Doc Pat, floor is yours.
Thank you, Doc. Share my screen. Is my screen visible na, Doc?
It's visible.
Okay. Good morning, everyone. It's me again, Patrick Mabugat, resident surgeon from Corazon Locsin. I'm a third-year resident, surgical resident of here in Bacolod, the land of Mascara and Chicken Masal. So today I'll be giving your Quizmaster session. I'll be giving rationale. You've already seen the questions. So it's basically 10 items of multiple choice questions along with quick fire questions, because around 10 later on. And I'll be giving the rationale now. So I hope this may be able to help you in your board exams. So for the first question, in a patient with medullary thyroid carcinoma, which other clinical features would be present if the patient would be diagnosed with MEN2A syndrome? Let me forward the timer. The correct answer would be letter A, pheochromocytoma and primary hyperparathyroidism. Now, good mnemonic I've learned during my board review season as the P and M mnemonic. Now, for MEN2A, we have the mnemonic PPM. Your MEN2A is also known as your Sippel syndrome. What's PPM? Pheochromocytoma, primary hyperparathyroidism, and MTC, or medullary thyroid carcinoma. Your letter B is actually your MEN2B or your PMM, otherwise known as your Wegenmann-Frobe syndrome. So again, it's PMM, pheochromocytoma, Marfanoid habitus or mucosal neuromas, and again, MTC. Now for your MEN1, that's your PPP, pituitary adenoma, pancreatic tumors, and parathyroid hyperplasia. Now, as you can see in this diagram, you can see that your MEN1, your 3Ps, share parathyroid hyperplasia with your MEN2A. And your MEN2A and MEN2B share both MTC and pheochromocytoma. Again, our mnemonic is MEN1, that's PPP, MEN2A, that's 2Ps, 1M, MEN2B, that's 1P, 2M. Okay. Now, a good question to ask is, medullary thyroid carcinoma exclusively associated with your MEN syndromes? The correct answer is no. And actually, more commonly, your medullary thyroid carcinoma is sporadic. When we say sporadic, it means that it occurs in the individual. It's not familial, it's not genetic. 75% of the time, it's sporadic. Now, if it's sporadic, it's most usually unilateral. If it's familial or genetic, it's usually bilateral. So for MTC, what's the cell type involved in your pathology? It's your parafollicular C cells. When we say parafollicular, para means beside the follicle. Now, what's the C there? The C actually is a good mnemonic for the marker or its hormone, which is produced by your parafollicular C cells, your calcitonin. Your calcitonin, remember, helps in regulating your serum calcium as opposed to your PTH. What are the important markers of your MTC? Now, your MTC, again, being composed of your parafollicular C cells, again, produces the city marker of your calcitonin. Along with your calcitonin, you have your CEA. A good mnemonic for that is, again, your CCC. Parafollicular C, calcitonin, and CA for MTC. What's the diagnostic finding in your FNAB? The diagnostic finding in your FNAB for your MTC is amyloid. So amyloid usually stained by your Congo red stain, and it's made up of your beta sheets. Next, number 2, What's the most important component of surgical repair in an infant with unilateral inguinal hernia? So the principle of repairing an inguinal hernia in a pediatric patient is different when compared to adults. In adults, the most important thing is you need to reinforce the tissues. So you can either apply a synthetic or a biologic mesh. In children, or sometimes you can do a RAFI if the tissue field is not contaminated. In children, however, because the most common reason of a pediatric inguinal hernia is a patent processus vaginalis and not weakness of the abdominal wall, the only thing you actually need to do is you need to do a high ligation of the hernia sac. Sometimes what we call your herniotomy. Okay, what causes majority of cases of inguinal hernia? It is your PPV, your patent processus vaginalis. Your patent processus vaginalis basically a tract of peritoneum going down to your scrotum alongside with your testis. Usually it obliterates after you're born. However, in patients with hernia, this persists. Okay, if your PPV is the most common cause of your inguinal hernias, it follows that the most common type of inguinal hernia is an indirect hernia because indirect hernias are caused by your PPVs. Okay? Now, what refers to partial closure of the PPV with entrapped fluid? Again, you have your PPV there. If it's patent, you call it, again, a hernia. However, if there's partial closure at 1 or 2 points, you call this a hydrocele. Hydrocele meaning it's just a sac of fluid. Okay? A positive finding of your hydrocele, a positive sign of your hydrocele is your positive transillumination test. What is transillumination? You shine a light. If light passes through, then it's most likely a hydrocele because it's only water. But a negative transillumination means it doesn't light up, means there's bowel or omentum inside. Most commons in inguinal hernia, it's more commonly associated with males rather than in females. Na 10:1 ratio, and it usually happens more often in the right side than the left side. That's why historically, if you have a hernia in the left side, which is uncommon, you need to do an operation on the right side also. But that has been disproven more recently. What are the indications for surgery of hernias in hydrocele? Now, if you have an inguinal hernia, the mere presence of an inguinal hernia is an indication for operation. It's scheduled electively or emergently if the patient is experiencing signs of incarceration or strangulation. How about the hydrocele? A hydrocele is operated on if there is no resolution by the end of 12 months. It's for your hydrocele. How about for umbilical hernia? Although umbilical hernias are not part of your inguinal hernias, I've included them here because these are keywords in your pediatric hernias. For umbilical hernias, no response by the age of 4 to 5 years old. Next, number 3, a full-term healthy newborn boy is noted to have imperforate anus. After 24 hours, no meconium is visualized in the perineal area. No fistula are also noted. A high-type defect is entertained. The most appropriate management should be, so the correct answer here, is B. A colostomy. Although in your Quizmaster question slide, it's sigmoid colostomy, still correct. But I've changed it here just to emphasize that for most surgeons, pediatric surgeons, they would actually recommend a transverse colostomy rather than a sigmoid colostomy. But among the options is the only one that's viable, the sigmoid colostomy. Okay? Why not observation? Because if the patient is obstructed, you need to operate on the patient. Why not do a diverting ileostomy? The ileum is very far from the rectum or the anus. The obstruction is in the rectum. Therefore, you need to divert just above the rectum for it to be physiologic. And remember, ileostomy has a very high output. You could lose so much fluids that patient will come back to you with electrolyte imbalance. So ileostomy, as much as possible, is not recommended unless the obstruction occurs in your ileocecal valve or ascending colon. Okay? Why not do a primary perineal repair? Because a primary perineal repair can only be done in patients with a low-type defect. Because a high-type defect requires a very complex surgery, not a very complex, just a very more complex surgery than a low-type defect. Okay. What's the pathophysiology of your imperforate anus? Failure of the rectum to the center of the external sphincter complex. So if it's above the sphincter, can push poop out, right? So you have two types. You have the high and the low imperforate anus. For the high imperforate anus, you can differentiate it from the low type because it's above the levator ani muscle. The low imperforate anus is below the levator ani muscle. Okay. For high type imperforate anus, what do? You first divert. You may do a single stage procedure and do anorectoplasty, or you may allow time to do a PSARP or anorectoplasty later on. What's your PSARP? Posterior sagittal anorectoplasty. Remember, imperforate anus, that's anorectoplasty. For your Hirschsprung disease, which is again not imperforate, a Hirschsprung disease is more functional. It's due to a lack of ganglion cells. It's due to lack of relaxation of the sphincter. There's a hole there, but it does not relax. That's your Hirschsprungs. For Hirschsprungs, it's a pull-through procedure. Remember your swab, Duhamel procedures. For the low type imperforate anus, because it's low type means it's very near to the skin at the onset, especially if you see a fistula, if you see a very shallow fistula, if you see just skin covering it, you can do a perineal incision with or without a colostomy. Okay, why without? Because there are some fistulas that require a colostomy even, especially if it's complicated. But generally, for low imperforate anus, you don't do colostomy. You just do a perineal approach, sometimes called your cutback anoplasty. Okay, what refers to the presence of a fistula, meconium, or urine in a patient with imperforate anus? It means that the patient most probably has a low type imperforate anus, and you can do cutback anoplasty. Next, what's the most common type of fistula in males? The most common type of fistula in males is a rectourethral fistula. Rectourethral fistula. In females, you have a rectovestibular fistula. The vestibule is the opening of your vagina. Again, in males, it's the urethra. In females, it's the vestibule. Next, the most commons in imperforate anus malformation, you have your urinary tract defects. And sometimes they share a very thin wall or a common wall. That's why when you do PSARP, you take care not also to injure the urethra. Skeletal defects, you have your, what's closest to your rectum? It's your sacrum. Sacrum is close to the rectum. That's why it's most commonly affected also. GI defect. In patients with imperforate anus, we always try to insert an OGT, and check for OGT placement in the chest x-ray because patients with imperforate anus sometimes have your esophageal atresia. So sometimes you might wonder, you've already operated on the anus, but or you've already did a colostomy, but every time you feed the patient, he's still vomiting up because again, imperforate anus may be associated with your esophageal atresia. Next, number 4, indications for operative expiration in neck injuries, except. So this may be a bit confusing, but the correct answer would be your transcervical gunshot wounds. It does not mean that if a person has been shot through the neck with a bullet passing through and through, you're going to operate on the patient immediately. Sometimes you may do workup first or you may observe. So we have 3 zones of the neck. Zone 1 is below the angle the clavicles. Zone 2 is the clavicle to the angle of the mandible. Zone 3 is the angle of the mandible above. Now don't get confused. Earlier references of Schwartz, I think Schwartz 8th edition to more the earlier editions, they make use of the cricoid as the border of the zone 1, 2. But again, it's the clavicles for us more recently. Indications for immediate intervention include hemodynamic instability, external hemorrhage, or evidence of aerodigestive injury. So you can do OR on these patients. However, we can stratify them into their stability and for the soft signs and the hard signs that we find. If the patient is unstable, place the patient in the OR immediately. If you see uncontrolled hemorrhage, hemoptysis, and a hematoma, and the patient is at risk of compromise or exsanguination, you can place the patient in the OR immediately. However, if the patient is stable with soft signs such as dysphagia, venous bleeding, slow oozing, subcutaneous emphysema, which means there's an air digestive tract injury, hematoma, hoarseness, stridor, or dinophagia, we are still afforded time to do workup first. So for vascular injuries, we usually do a CT angiography The CT will also identify L-digestive injury sometimes. Okay. If it's in the zone 3, you can do angioembolization. Why? Because it's very hard to access the zone 3 injuries. Now, if it's positive, you can proceed with angiography, esophagogram, or bronchoscopy, and you can do OR in the patient. If the patient is symptomatic, especially in zone 2, zone 3, even though it's transcervical, meaning it passed through the neck from one point to another, you can still conservatize the patient. You can still observe. What's the best diagnostic modality for vascular injury of the neck? So vascular, you think angiography, it's your CT angiography. Next, hemophilia is most often a result of iatrogenic injury to the, so the correct answer for this one is your right hepatic artery. Hemophilia, hemo means blood, bilia means bile. There's blood coming out of your bile ducts, okay? So what's the presentation of your hemophilia? It's your Quincke's triad hemophilia. It's upper GI bleeding, jaundice, and right upper quadrant pain. A good mnemonic for that would be your hemophilia. Just remember mob in between those words, right? What is MOB? Mob, melena, upper GI bleeding. What's O? Obstructive jaundice. What's B? Biliary colic or right upper quadrant pain. What's the underlying lesion in hemophilia? It is an arterial pseudoaneurysm after injury to the right hepatic artery. What's the treatment of hemophilia? We should call your friendly neighborhood interventional radiologist and offer the patient angiographic embolization if available. You just embolize the right hepatic artery which is bleeding, or the pseudoaneurysm which is bleeding. What's the most common aberrant vascular anomaly in the hepatobiliary surgery? It is your replaced right hepatic artery of the SMA. Remember, the right hepatic artery comes from your proper hepatic artery, which comes from your common hepatic artery, which comes from your celiac trunk. Below your celiac trunk, remember you have your SMA and your IMA. Okay. So the right hepatic artery is supposed to come off the hepatic artery, right? The common hepatic artery. However, in some cases, the right hepatic artery comes off not from the celiac trunk, but from the SMA. For the left hepatic artery, what's the most common anomaly? It is a left hepatic artery coming off from the left gastric artery. Next, a 60-year-old female presents with severe perianal pain for 12 hours after straining during defecation. Examination reveals a tender perianal mass with bluish discoloration under the skin. So what's the treatment? So the correct answer for this question is, elliptical excision under local anesthesia. Okay. Your A is used for internal hemorrhoids. Your B is used for abscesses. Stool softeners and sitz bath may sometimes be used, especially if the patient is not really that symptomatic. All right. In this patient, what's important to note is the P finding of a bluish discoloration, which would indicate there's most probably thrombosis of the hemorrhoids, and also the hours of symptoms. Patient's only been experiencing symptoms for 12 hours. So is it important? I'll show you in the next slide. So we have 3 hemorrhoidal plexus. We have left lateral, right anterior, and right posterior. A good mnemonic is your LL-RARP, left lateral, right anterior, right posterior. Now to treat, we need to identify if it's internal or external hemorrhoids at first. Internal means it's above the dentate line. External means it's below the dentate line. Don't get confused. Again, in imperforate anus, just so you don't get confused, it's the levator ani muscle in imperforate anus. Internal hemorrhoids, the border there for internal and external, it's a dentate line. Now, your internal hemorrhoids are covered only with your mucosa, same as your intestines. Remember, your mucosa has no sensation. Therefore, you don't feel pain. You feel there's blood coming out from your anus. Okay? It's usually bleeding, right? And your internal hemorrhoids have stages, while your external hemorrhoids don't have stages. A good point to remember also for external hemorrhoids is that they're covered by anoderm. Basically, they're covered by skin. And then your skin is sensate. You can feel your skin. So if it's sensate, one of the most important symptoms or earliest symptoms in the patients with external hemorrhoids is pain, especially if it's thrombosed. So as a treatment for internal and external hemorrhoids, it's medical initially unless the patient becomes severely symptomatic. For internal hemorrhoids, you need to grade by 1, 2, 3, and 4. Again, 1, it's not prolapse. 2, it prolapse but spontaneously reducible. 3, it's manually reducible. And 4, it's not reducible. It's already outside. Okay? For 1 and 2, you can do office bedside procedures such as your infrared photocoagulation, your RBL, your rubber band ligation or banding, and your sclerotherapy. For 3 and 4, you can offer more aggressive approaches, surgery such as your Milligan-Morgan open, Parks-Ferguson closed, or Whitehead's excision. Okay. For the external hemorrhoids, time is of the essence. If it's less than 72 hours, you can give excision. If it's more than 72 hours, you don't need to do an operation. Why? According to studies, after 72 hours, patients with external hemorrhoids, they usually resolve. They don't feel any more pain. So I can, again, manage it more conservatively with sitz baths and analgesics. A good point, because sometimes, I've seen questions when the examiners will try to confuse you. They're trying to give you a very benign case of external hemorrhoids, and they're going to try to push you into answering rubber band ligation. Well, that is not the correct answer. Rubber band ligation, even though it looks very simple, is only offered for internal hemorrhoids. Why? Again, external hemorrhoids, they're covered by skin, they're covered by anoderm, therefore you cannot band them because when you put a rubber band around them, it's gonna be very painful. For 7, what's the percentage of patients with myasthenia gravis who will improve after thymectomy for a patient with thymoma? The correct answer for this question is letter A, 25%. Okay, so what is myasthenia gravis? First, we need to identify its pathophysiology. The antibody involved in your myasthenia gravis is acetylcholine receptor antibodies. So what does it do? Remember, acetylcholine is very important in muscle transmission for contraction of your muscles, right? So if you have antibodies against acetylcholine receptors, the more you try to activate the receptor, the more the antibodies will bind. The more you use your muscle, the more they will weaken. Your MG, your myasthenia gravis, should be differentiated from your Lambert-Eaton syndrome. Remember, Lambert-Eaton syndrome, the problem is not with your acetylcholine receptors, but your voltage-gated calcium channels. Now, what's good about your voltage-gated calcium channels? They're numerous. So if you have antibodies affecting one channel, the more you use that muscle, the more channels will open. So the more channels will open means that even if you're weak at the start because you have antibodies against the voltage-gated calcium channels, the more you use that muscle, the more calcium channels will open. It will improve with use. Now, 50% of patients with thymoma have a positive acetylcholine receptor antibody. That's why the thymus has been proposed to be one of the reasons why myasthenia gravis develops, because thymoma is associated again with the antibody which causes your myasthenia gravis. That's why scientists and physicians have researched and have suggested that removal of the thymus in patients with myasthenia gravis is actually helpful. Okay, in studies, thymectomy or removing the thymus in myasthenia gravis without a thymoma, take note, leads to complete resolution in 50%, and they improve in almost 80 to 90%. Okay? However, if you have a thymoma, complete resolution occurs only in 25%. Now, this might confuse you. Doc, you said thymoma is associated with acetylcholine receptor, with myasthenia gravis. Why does it have a less percentage of resolution? The way I like to think about this, my mindset about this, is that in patients with thymoma, they have a larger thymus. They have a aberrant, a problematic thymus. So if you remove that thymus, it's not going to probably affect much. As compared when you're removing a normal thymus, which is just very small, if you remove it, MG resolves almost completely, 90%. But if you have a thymoma, it's very big, so only 25%. So don't get confused. I know numbers may be pretty boring at times. However, the problem is that this question has been popping out in the board exams. So I need you guys to somehow take your time and understand this part of your surgery review. Okay. Number 8, what's the best test for localization of a gastrinoma? The best test for localization of a gastrinoma, I saw most of you had the correct answers, is an octreotide scan. So, according to Schwartz, what's the worst prognosis of all malignancies? Is your pancreas. As they said, in patients with stage 3 to stage 4 pancreatic CA, you are afforded an average of 6 months, but that has since been improving with the advent of very capable adjuvant chemotherapy and more advanced surgeries. Right? That's why the pancreas is the most unforgiving organ in the body. As I said, what are the 3 tenets in surgery? It's eat when you can, sleep when you can, and number 3 is don't mess with the pancreas. So we don't usually touch the pancreas unless we need to. What's the most common malignancy of the pancreas? It's your adenocarcinoma. Remember, your pancreas is made up of exocrine and endocrine glands. Glands, in scientific terms, that's your adeno. So adenocarcinoma is your adenocarcinoma glandular CA of your pancreas. What's the most common pancreatic endocrine tumor? Remember, you have an exocrine part of your pancreas and you have your endocrine part. Now, for this one, lots of students get confused. The most common pancreatic endocrine tumor, remember, endocrine, you're going to think of a hormone, you're going to think it's very functional, but actually it's not. The most common pancreatic endocrine tumor is actually non-functional. Okay, it doesn't work most of the time. Okay. However, if you're asked what's the most common pancreatic functional endocrine tumor, you're going to answer insulinoma. I've seen some students answer gastrinoma, but I'll explain next slide. As in your Schwartz, the most common functional endocrine tumor is your insulinoma. If they don't place functional there and there's a non-functional in the options, you answer non-functional. What's the medical management of functional neuroendocrine tumors of the pancreas? So it's octreotide, which is antagonist to your hormones, except in insulinoma. In insulinoma, we usually offer surgery outright. So here's a good diagram showing your gastrinomas, your somatostatinoma, your insulinoma, your VIPoma for your pancreatic tumors. So what's again the most common pancreatic islet cell tumor in men 1? It is your, remember your men 1 is your parathyroid hyperplasia, your pancreatic neoplasm. Your men 1 is associated with your gastrinoma. Okay? Most common again, pancreatic endocrine tumor, it's non-functional. Sorry, most common tumor overall is adenocarcinoma. Most common endocrine tumor, that's your non-functional. Most common functional endocrine tumor, that's your insulinoma. Most common pancreatic tumor in men 1, that's your gastrinoma. Okay, so how does gastrinoma present? It's usually refractory peptic ulcer disease despite continuous and constant proton pump inhibitor and H. pylori treatment. So you're gonna think if you have very high basal acid output and it's not getting treated on by your gastro with PPIs and your H. pylori, you're gonna think of gastrinomas. So gastrinoma triangle is important because if you try to find the gastrinoma, it's usually within these 3 parts. Your gastrinoma triangle is otherwise known as your Passar's triangle. So it's either in the cystic duct CBD junction, the pancreatic neck body junction, or the second and third portion of the duodenum. Okay, that's your gastrinoma or Passar's triangle. What's the diagnostic test for your gastrinoma? It's your fasting serum gastrin and your basal acid output. Okay, you have increased levels of gastrin, and of course you're going to think of a gastrinoma. What's the confirmatory test? So I think this has been popping out also in the board exams. Your secretin stimulation test. Secretin is going to increase somehow your gastrin. However, in patients with gastrinoma, it's going to increase exponentially. What's the single best study for localizing your gastrinomas? It is your octreotide scan. Because again, your octreotide antagonizes gastrin. So it tries to find your gastrin. So you use octreotide, radiolabeled octreotide to identify your gastrinomas. If not found, so this is just, I think, a trivia question. If you don't find the gastrinoma, what do you do? Remember, it's in the Passar's triangle. If you don't see it in a CT scan, a octreotide scan, you try to open up the duodenum. You do a duodenostomy. Okay? You try to open up the duodenum. Okay, number 9, 50-year-old male, hospitalized and bedridden for a month, maintained on high-dose opiates, presents with distended large bowel loops on x-rays. So what's the diagnosis? Okay, the diagnosis for this case is your Ogilvy syndrome or acute colonic pseudo-obstruction. Okay, so why is it not sigmoid volvulus colonic new growth and diverticulitis? Unless you have risk factors for those: sigmoid volvulus, constipation, colonic new growth, smoking, old age, with alarm features, diverticulitis, again with constipation, but usually present as a septic patient. If you have a patient with the Ogilvy syndrome, you're going to have a patient who's bedridden, those are keywords, on opiates or narcotics with large bowel loops. What's again the other name of your Ogilvy syndrome? It's your colonic pseudo-obstruction. Why pseudo-obstruction? Because everything is obstructed, but if you check the imaging, if you open up the patient, you're not going to find any problem. It's the absence of mechanical dilation, obstruction, which qualifies the patient as having Ogilvy syndrome. So this one. What's the initial management? The initial management is, again, cessation of the underlying cause. So cessation of narcotics, anticholinergics, other medication. You can do strict bowel rest, can do hydration. Failure to improve, you can do a colonic decompression for the patient. Okay. What's the medical management for colonic pseudo-obstruction? Remember that your choline receptors are important in peristalsis. Okay, so you need to increase the peristalsis. You give your neostigmine. So your neostigmine will stimulate peristalsis to occur. It's avoided in bradycardia and cardiopulmonary disease, however, because it may again aggravate the bradycardia. And for our last question, 70-year-old female presents with massive lower GI bleed, hypotension, and pallor. After volume resuscitation, the BP normalizes. NGT is inserted and is negative for blood. What's the next step? So the correct answer would be your anoscopy or proctoscopy. Now let me explain the next slide. What's the most common cause of lower GI bleeding in the elderly? The correct answer is your diverticular bleeding. So diverticular bleeding means there's bleeding from your diverticulum. If you have lots of those diverticulum, it's going to be called your diverticulosis. If you're going to have an infection of the diverticulum, you're going to call it diverticulitis. So it's different, right? Diverticulosis presents with bleeding. Diverticulitis presents with infection. Okay. After stabilization, so the first thing you should do, you should stabilize the patient. Check history PE, give hydration, so resuscitate the patient. Next step, you should insert NGT. Why NGT first? Because upper GI bleed is more common than lower GI bleed, and it's easier to rule out by just placing an NGT and checking if there's blood per NGT. Okay, so you can rule out upper GI bleeding, which now gives you the lower half of the GI to rule out and identify which one is bleeding. If there's no blood in the NGT, what you should do next is do proctoscopy and anoscopy. Why? Proctoscopy and anoscopy is used to identify internal hemorrhoids, which is the second most common of your lower GI bleeding. If you don't see hemorrhoids, you need to go further. So you need to do colonoscopy. You should push it to the sigmoid colon, descending colon, ascending, and transverse and ascending to identify other sources of bleeding. If you have worked up the patient, you can identify it, and still with massive bleeding, and the patient is stable, that's important, you need to do arteriography to identify what vessel or what part of the colon is bleeding. If the patient is unstable or if the bleeding recurs, you need to do exploratory laparotomy. You need to try and localize the source of bleeding. However, if the patient is already unstable and you don't have time to identify the source of bleeding, you do XLAP and you do total colectomy. You remove the whole colon. You don't have time to identify the bleeding source. That's our 10 questions. So I still have quick fire questions for you. What's the vessel associated with the recurrent laryngeal nerve injury? The recurrent laryngeal nerve, again, the recurrent laryngeal nerve goes, the vagus nerve goes down, and then it's separates into superior and the inferior, then it goes back up. If it goes back up, it's recurrent because it recurs, it goes back up. If it goes back up, it comes from the bottom, so it's the inferior thyroid artery. Okay? For your superior thyroid artery is your superior laryngeal nerve. Remember, current laryngeal nerve injury will predispose to dysphonia or dyspnea. Okay? Because your vocal cords will either be paralyzed or closed. What's the most common root of insensible water losses? So remember, the most common root of insensible water losses is the skin. That's why in pediatric patients, you need to cover them up and maintain normothermia for the patient and not hypothermia. Okay? Next was a good indicator of nutritional status for esophageal resection and esophageal cancer. So a good indicator of nutritional status is your albumin. Okay, albumin generally is a good nutritional indicator. Some references might also include your pre-albumin and your leukocyte or your segment or your neutrophil count as indicators for nutritional status. For esophageal cancer, however, one important parameter in identifying resection is the good FEV1 score. I think I've already mentioned that. Next, what's the most common source of arterial thrombotic emboli? Of course, from where all blood usually gets pumped through your heart. So the heart, especially if you have vegetations there, if you already have malfunctioning valves there, if you have atrial fibrillation especially, which is the most common, it can predispose to embolization. Next, what's the Leitz criteria for exudative effusion? So we use this in thoracic surgery. PF serum protein ratio of 0.5, PF serum LD ratio of 0.6, and a PF LD ratio more than 2/3 of upper limit. So it's 0.5, 0.6, that LD 0.6 can also sometimes be used as a 2/3 upper limit of normal. Next, was tried associated with insulinoma. It is your Whipple triad. What's a Whipple triad? It is symptoms of hypoglycemia, CVG level less than 60 or 70 in some references, and resolution upon giving back glucose source such as your dextrose. Next, fracture of the proximal third of the ulna with a dislocated radial head. We have your Monteggia fracture. I think I've already discussed this in my previous lecture. Most common adrenal tumor discovered incidentally on a CT scan would be your adrenal cortical adenomas. So adenomas usually are common. So I usually aim for adenomas when I'm thinking of an organ system with benign tumor. So I think of adenomas. So the answering adenoma in this question will be I think, very lucky if you answered it. What's the most common site of an ectopic testis? It's the superficial inguinal pouch, so just above it, okay, just above where it's usually found, superficial inguinal pouch. And finally, sometimes you have anesthesia questions in your surgery exam. What's the mechanism of action of your lidocaine? It's a blockage of voltage gauge sodium channels. Okay, so that's our call for quick fire questions. Before we end, as you go along, I don't want to greet you with good luck, because I really don't believe in luck. Luck for me is non-existent, and saying good luck to a person for me defeats the purpose of that person working very hard. Because if you work very hard, you're going to have more chances to succeed and more chances to reach your goals. I'm sure you guys can do it. So instead of saying good luck to you guys, you have a couple of days left, but I'm sure you all did a very good job. So I'll say good job instead of good luck. That's all for my lecture.
That's a very wonderful sentiment. Indeed, I believe my group has worked very hard. Good job, my section. Okay, so eksakto tayong 1 hour. Thank you for bearing with me. And thank you, Doc Pat, for joining us. Thank you. And for your from duty status, thank you. Magpahinga ka na. Salamat po for taking the time out with us. All right, everybody, get to it. Thank you for waking up. The whole purpose really of the Quizmaster is to get you into the discipline of waking up early, 7 a.m. Remember your classes. Remember, according to the PRC, you have to be in your designated rooms on the first day by 5:30 a.m. I don't know if that, I hope that's exag or ina-expect lang nila malilate kayo. Nevertheless, please start waking up early. Get your body clocks attuned already, please join us for the Quizmasters. Thank you very much. Continue studying today. I leave you with one of our favorite new send-offs, no? Here we go.
You can be the greatest, you can be the best, you can be the King Kong banging on your chest. You can beat the world, you can beat the war, you can talk to God, go banging on his door. You can throw your hands up, you can beat the clock, you can move a mountain, you can break rocks. You can be a master, don't wait for luck. Dedicate yourself and gonna find yourself standing in a hall of fame. And the world's gonna know your name, 'cause you burn with the brightest flame. And the world's gonna know your name, and you'll be on the walls of the Hall of Fame.
You can go the distance, you can run the mile, you can walk straight through hell with a smile. You could be a hero, you could get the gold, breaking all the records you thought could never be broke. Do it for your people, do it for your pride. How you ever gonna know if you never even try? Do it for your country, do it for your name, 'cause there's gonna be a day when you're
standing in a Hall of Fame. And the world's gonna know your name, 'cause you burn with the brightest flame. And the world's gonna know your name, and you'll be on the walls of the Hall of
You can
Fame.
be a champion, you can be a champion, you can be a champion, you can be a
You'll be on the walls of the
champion.
Hall of Fame.
Past failures may haunt you, you yourself may doubt you, but don't let none of it discourage you and stop you, block you from reaching your goals. Just believe in your own capability, ability to aim for the stars. You will overcome this war, you'll be licensed to heal and be licensed to help. This is for your mama and this is for your papa. Know that pain is temporary, but your license
Standing in
is
a Hall of
forever.
Fame. And the world's gonna know your name, 'cause you burn with the brightest flame. And the world's gonna know your name, and you'll be on the walls of the Hall of Fame. You could be the greatest, you could be the best, you could be the King Kong banging on his chest. You could beat the world, you could beat the war, you could talk to God, go banging on his door. You can throw your hands up, you could beat the clock, you can move a mountain, you can break rocks. You can be a master, don't wait for luck. Dedicate yourself and gonna find yourself standing in a Hall of Fame.
Have a nice day, everybody.